right, this is Intentional Aging for December 2023. And today, Priya Jayadev, Executive Director of Volunteer Hospice of Clallam County, is here to talk about palliative and hospice care. So I am going to turn things over to Priya. Priya, thank you so much for joining us today, and welcome to Intentional Aging.
Thank you, Karina, and happy holidays to everyone. I am excited about closing out 2023 with a presentation and talk about hospice and palliative care. And I have a tendency to talk fast. So since you can't throw anything at me, just indicate somehow if you want me to slow down or if you have questions. I don't mind being interrupted throughout. So please feel free. Okay. So let me start out by giving you a couple of quotes. So death and dying, it's not a conversation most of us want to talk about. It's a difficult topic, right? And psychologist Corinne Sweet actually says it really well when she says, people find death a difficult topic to discuss as it usually brings up a lot of feelings, anxiety, fear, awkwardness, sadness. We tend to pretend as a culture that it's not going to happen. But as the comedian John Cleese says, life is a terminal disease. So we're all going to get there, right? I mean, that is the one guarantee. Death is going to happen. And the key thing I hope you walk away with today is that no matter what, the better you are prepared and you are ready to accept that end of life process, the better that actual dying process will be. And I hope you'll walk away with that sense of dying is not just the grim reaper and sadness and anxiety, but it can actually be a joyful process and can actually be done in a manner that is very humane and makes everyone feel like there's been richness throughout as well as in that end of life process. So to the point that it is a terminal disease, let's talk about death and that life is a terminal disease. Let's talk about death and dying. So in the olden days, well, people used to die young, right? They were dying in their infancy, in childhood, at childbirth, during young adulthood. But as the population has improved in terms of medical care and so many other areas of the community have improved in terms of environment and just how we live our lives, you can see that deaths are going up. The main thing you want to see from this table isn't that there's a lot of numbers, but the fact that if you go from lower to higher numbers in terms of age, and 2021 and 2022 numbers, is that more people die at ages of 45 and above, right? Death is not happening young now. It's happening mostly to older adults. In fact, in 2022, 3/4 of the 3.3 million deaths that occurred were to people 65 and older. And it's predicted that by 2030, 1/5 of the US population will be at least 65. So if you combine that, we are an aging population. We have death and dying as a key part of that consideration as we age. And the fact that because we haven't talked about death, because we haven't thought it through, because we haven't prepared, most life deaths occur following a prolonged period of chronic illness, discomfort, or cognitive impairment. Some of this can be managed better than other situations, but the point is that the more we talk about it, the more we plan, the less pain and suffering. Yes, there can be chronic illness. Yes, there can be discomfort. Yes, there can be cognitive impairment, but it can be handled very much in different ways depending on how we prepare. And to that point, in terms of the death and dying process, in the US, death and dying is often characterized by fragmented care, inadequate treatment of distressing symptoms, frequent transitions among care settings, and an enormous care responsibility that falls to families. Right? Families often face a decision-making process of pursuing an aggressive treatment. And by aggressive treatment, I mean surgery, repeated emergency visits, hospitalizations, ICU admissions, all of that aggressive treatment piece that can lead to an uncomfortable death or not doing that and feeling guilty about that process, right? In fact, in our culture, aggressive end-of-life care is widespread, young and old, right? And it happens partly because of our culture, and often because many of the people that are dying are in settings like nursing homes where there's a mandate to actually do aggressive treatment. So it is critically important that you talk to wherever you live, the people you're surrounded by, and make sure they are in agreement with you in terms of how you want your death and dying process to be, right? And one other piece of statistic, patients who receive the type of aggressive care that I've been talking about, experience more pain, actually die sooner, have a much poorer quality of life at the end, and their families experience more doubt and trauma. So the more we talk about it, the more we prepare, the better off we are in terms of easing discomfort, easing pain, easing stress and grief, and many of those things. And if you look at the studies that have been, greater than 80% of Americans prefer to die at home, but only 25% actually occur at home. The majority of people die in hospitals and nursing homes, which is sad, right? I mean, let's have things happen more the way that people want. And part of that is because the healthcare system in the US is set up as a fee-for-service payment system, right? Every visit is a billing, right? And that is the mechanism by which we operate. It is the medicalization of death. It is not death as a natural flow of the life process, but more of sorry, I have a sore throat. More of a process of, how can we cure? Let's do everything we can to save that life, no matter how difficult that life is, even in that period. People greater than 65 and older consume more than a third of personal healthcare spending in the US, mostly for inpatient services, primarily funded by Medicare, and nursing home facility services, primarily funded by Medicaid. In the US, a quarter of elderly medical expenditures are in the last year of life, right? Healthcare dollars spent in the US exceeds $4.3 trillion, which represents 19% of our gross domestic product. The amount of money spent in the last months of life, $1.2 trillion. It is an industry that is expensive. And to that point, Medicare has recognized, and there are studies that are out there that have recognized that putting someone on hospice care, putting someone on palliative care, providing services that are hospice and palliative in nature actually can save Medicare and Medicaid and other insurance and private spending dollars. NORC at the University of Chicago, which does a lot of research studies to help inform governmental decision-making, has shown that hospice saved Medicare $3.5 billion. If someone was on hospice for greater than 10 days of hospice care, there's significant decrease in end-of-life costs. If someone is on hospice for more up to 6 months or more, it saves Medicare 11%. That is huge. Hospice care also leads to greater satisfaction, better quality of life for both the patient and the family. And the hospitalization and the hospice utilization leads to improved clinical outcomes. You hear the stories. My so-and-so went on hospice and they lived longer than we expected, right? It's that piece of stress relief, that piece of, I'm getting the care that I'm needing. I'm not stressing out about going to the ER and getting what I need to continue to survive, but it's about thriving in that end of life process. And we've seen the stories since Jimmy Carter's been on hospice, right? He's outlasted 6 months, right? He's longer than 6 months out. We've seen the headlines, peanut butter ice cream and his 99th birthday. That's what characterizes Jimmy Carter on hospice. His wife, Rosalind Carter, recently passed on hospice. She was on only for a few weeks or days, as I recall. But the entry into hospice actually leads to improved pain control, reduced physical distress, reduced emotional distress, which produces that relief piece, which results oftentimes in not only a better end of life process, but actually potentially an increase in the time that someone is alive. So then I'm giving you these terms, hospice, palliative care. What the heck does that mean, right? Well, so there are two things that I want to point out. Hospice can end the medicalization of people. It lets people live until their last breath. And this society in Hong Kong says it best. When days cannot be added to life, add life to days. That's it in a nutshell. That is hospice and palliative care in a nutshell. Adding life to days. So let's go through some general definitions. Palliative care. I'm looking over here because I've got you guys set over here. Let me do this. Okay, so palliative care is specialized medical care for people living with a serious life-limiting illness. Life-limiting. Not that you are going to die immediately. It is not a death sentence. You have a life-limiting illness. Cancer, Alzheimer's, heart disease, diabetes. There are a lot of life-limiting illnesses, right? But when you're in those stages where that life-limiting illness is actually impacting your lifestyle, that is when palliative care is available. The emphasis is on communication, continuity of care, fits with episodic and long-term nature of serious, multifaceted illnesses. Palliative patients receive comfort and curative care, right? So a cancer patient on palliative care can continue to have chemotherapy, can continue to have radiation, can continue to go in for treatment of UTIs and all of the other things. Curative treatment continues in conjunction with palliative care, which is the comfort, pain management piece of care. Palliative care helps make patients make critical medical and treatment decision. The focus is on quality of life, symptom burden easing, emotional well-being, and supporting caregivers. It is social, it is emotional, and it's practical support. And it involves an interdisciplinary team, which I'll go into a little bit later in terms of the composition of what that looks like. But the composition can vary based on the level of acuity or the need of the patient and the level of care that that patient needs. Currently, palliative care really is not funded, right? There's a huge conversation happening even at the federal level at Centers for Medicare and Medicaid Services, CMS, of whether palliative care should be funded, right? And that is an active conversation. And I would ask for those of you that are advocates and active in policy and such, advocate for funding for palliative care. It is so needed, so needed. It is so valuable. Raise your voice and ask for funding for this. And then hospice care, which is a subset of palliative care because it focuses on end of life, those final few months, those final few weeks, final few days, is that piece of palliative care that focuses on that end of life piece. Hospice is not the grim reaper. It is just because someone goes on hospice doesn't mean they're going to die faster. And in fact, anecdotal data shows that people go on hospice and actually live longer than expected, right? So it is not the grim reaper coming in just because you've been put on a hospice caseload. And that is a critical thing for people to understand. Hospice care improves end of life process. And so many times we hear families say, I wish I had gotten so-and-so on hospice sooner. It would have been so much better for us. Instead of saying the I wish, if you think someone's ready for hospice, investigate, get them on hospice care. If they're not eligible for hospice, perhaps they're eligible for palliative. And here in Clallam County, there is that option for both palliative and hospice care because you have a unique organization here. And I'll get into that in a minute. Usually with hospice care, the patient is expected to have less than or equal to 6 months of life expectancy. If the disease that is the terminal disease, the life-limiting disease, follows its usual course of disease progression. That's a critical thing. No one can predict, right? We just have data that says, oh, usually person at this stage of this disease, they have this many months. The statistics are statistics because maybe the 10% that survive, there have been a consistent number of 10% that survive. Maybe the person you're talking about is part of that 10%, right? Longer, right? So it's the usual course of disease progression leads to end of life in less than or equal to 6 months is the usual definition of hospice care. Hospice care in general, as it's in the US, is supportive rather than curative. Most people on hospice care, and if funded by a private insurance, Medicare, Medicaid, cannot pursue curative treatment. That is not the case with us, but, and we'll get into that in a minute, but generally you go on hospice care, you're not pursuing curative treatment. And if you think about it, people at end of life really shouldn't be thinking about curative treatment. I mean, if you're preparing for dying, it should be focused on how do I make my dying process as comfortable as possible. Curative only when something is causing me pain or discomfort, but not curative to cure the disease, because at that stage, you're usually terminal and that person is not going to be cured at that point. So that letting go of that curative expectation is actually a stress relief for many. Care focuses in hospice care on quality of life, emotional well-being, and caregiver need. Exactly the same things that you saw in the palliative care. Hospice is a subset of palliative care, which focuses on the more end stages of end of life. Just like palliative care, social, emotional, and practical support is provided. It helps the patient make important decisions. It involves an interdisciplinary team, which can be variable depending on the level of need of the patient and family. Unlike palliative generally, hospice is generally reimbursed through Medicare hospice benefit, predominantly actually in the US, and other insurance. VHOCC, Volunteer Hospice of Clallam County, which is the organization I am part of, we don't bill anybody, and I'll get into that momentarily as well. I don't want to belabor this slide. There's lots of data, lots of little dots. What I want to give you is just a quick snapshot of hospice history. Hospice isn't a new concept. It was something that originated in the Middle Ages. In 1065 was where people believe the origin of hospice happened. There's been little bits and pieces of hospice here and there through the ages, but in 1967 is when the first real modern hospice was created by many who know this name, Dame Cicely Saunders. In the United Kingdom. And then Elizabeth Kubler-Ross in 1969 published this book called On Death and Dying, which really brought the conversation about death and dying to the forefront. And the first hospice in the US was formed in the early to mid 70s. What you need to realize is this little county, Clallam County, was a visionary county, this tiny little population county. Embraced the hospice concept in 1978 because of Rose Crump, who is an amazing, incredible visionary nurse in this community, and said, you know what, I don't care what anyone tells me about whether we need it or not, we need it. We need hospice here. So 4 years after it came as a concept in the format that it's into the US, Clallam County embraced the concept of a hospice and created Hospice of Clallam County, which later became Volunteer Hospice of Clallam County. There have been lots of changes throughout since the inception of hospice in the US as it is in the modern form. Medicare recognized that there's value in funding it, and in the early to mid 80s, Medicare created a mechanism to fund it, codified it, and it is a funded program now. And by 2004, over 1 million Americans were served by hospice, and that has increased since. And then there have been other things that have impacted the hospice movement, which includes the inception of the physician's order for life-sustaining treatment, or POLST, which is a mechanism whereby families and patients can make decisions and communicate those decisions on a piece of paper as to what I want for end-of-life care. And then death with dignity, or medical aid in dying, has come into play in Washington State in 2008, which is a mechanism whereby if you have two physicians signing off saying that you have less than or equal to 6 months to live, you can actually choose the time and place of death and aid that through medication assistance. And that is a process that is ongoing in the US in various states, in the majority of states, I think 37 states, including Washington. So I've given you some definitions, a little bit of history. Let's just recap a little bit. Palliative and hospice care can be offered in different settings. It can be offered in the home, which is where 80% of Americans say they want to die. So it can be offered in the home. Wow. Oh, that's great. It can be offered in a facility. It can be offered in hospitals. Majority of time, it is actually offered as home-based care. It involves an interdisciplinary team. And I said I would tell you about some of the people that may be on that team. The most important people are the nurse and the nursing aide, in the sense that they are the ones that have eyes on the patient on a regular basis. The nurse and nursing aide are always a component of both the palliative and hospice team. It can also involve a physician, a spiritual counselor, dietitian, grief counselors, volunteers, therapists, occupational speech, all kinds of therapists, and a social worker. And who is involved in that team can vary depending on the level of need of the patient. And Medicare and insurance actually stipulates who must be involved on a regular team as well. Who pays? As I said, hospice can be paid for by Medicare, Medicaid, insurance, HMOs, private pay, and it's sometimes a combination of these payers. Palliative is generally not funded. There are a few insurance HMOs that cover it, very few. It's pretty much unfunded right now, and it is a huge conversation, both at the state level and at the federal level, mostly at the federal level though, whether it should be funded. And it's something where you can add your voice to that discussion. The benefits, as I said, involve symptom management, emotional and spiritual support, and a coordination of care. As I said, hospice, subset of palliative care. The general idea is that you get a diagnosis of a life-limiting illness. You start disease-directed curative therapies. Palliative care takes in as the curative therapies get less and less or more reduced, get less and less in play. Palliative tapers until you get to a point where hospice is what takes over and you're no longer pursuing curative, but more comfort care. There's a lot of aspects of both hospice and palliative that are common, but there are some aspects, as I've gone through previously, that are not the same. So let me just touch on Medicare and hospice, because this is the majority of people, how they fund hospice in most areas of the country, not here, but in most areas of the country. Medicare does fund hospice, and it is the primary funder of hospice across the nation. Medicare has the absolute contingency that there must be a certificate of terminal illness. A physician must sign off that the patient, if they go through the normal course of disease process, has a prognosis of less than or equal to 6 months to live in order to get Medicare funded hospice care. Medicare also puts in the stipulation that if you get funded through Medicare for hospice care, you may not pursue any more curative medical interventions. So this is a sticky wicket, because you ask the question of curative, right? What about the patient who has a disease, but they've got, a yeast infection? Is it curative to pursue that? Will Medicare still fund the hospice need and the hospice benefit still active if you go to the hospital for treatment for the yeast infection? So there's been some really sticky wickets there in terms of this contingency that Medicare puts in place. Generally, if it's not curative for the disease that is causing end of life, it is allowable, but there have been some issues in certain situations. We don't have that issue because we don't bill. So we have a little bit more flexibility. In 2017, greater than 1.7 million. So remember when I told you, I think it was 2007, it was 1 million patients. In 2021, it was more than 1.7 million patients that were Medicare beneficiaries of hospice care. The spending for that care was $23.1 billion. It is a business, right? It is a mechanism for being funded for caregiving. Medicare hospice benefit is now over 40 years old. There are some questions about whether it needs to evolve from where it's at. There's some question as to whether that 6-month contingency needs to really be in place. Remember, when inception, when Medicare started funding hospice care, most of the patients were cancer patients. But now in 2020, greater than 20% of patients on hospice care have dementia that live an average of 181 days versus 97 days with cancer, right? After going on hospice. 10.2% have heart disease, 7.2% have cancer. So there's a conversation that's ongoing as to this arbitrary designation of less than or equal to 6 months with normal course of disease. Is that something that needs to happen, or should we change that timeline? And there's also a question about funding models, because it is a pay per day model of funding, where the patient number times the level of need of that patient times the days on service equals how funding happens for Medicare hospice beneficiaries. And so there is, unfortunately, a few, not the majority, a few cases of fraud and profiteering from the Medicare hospice benefit. So there is some question about some change happening in the hospice benefit. I just want to touch on the fact that Medicare hospice utilization varies state by state across this nation. Washington ranks 37th in the nation. 46% of the people who should get hospice care are actually receiving it. Less than 50% of those needing hospice are actually getting that, right? Again, to that point of hospice is not the grim reaper. It is that perception piece that we need to change so that we can change the statistics so that it's more than 50%, so that we're not 37th in the nation in terms of utilization of hospice care. But remember, we don't count in that. Our service numbers don't count in these numbers because this is Medicare based numbers and we don't go into those numbers. So we're kind of operating in this other area that our numbers don't get captured in this. But we only serve Clallam County, and it's not a large number in relation to the state, right? So we're not going to influence that number all that much. And since I've talked about the Medicare hospice benefit, let me just tell you that as it's laid out in periods, with the initial 90 days of care being billable at a higher rate than the second 90 days. And then there's a need for recertification if somebody stays on longer than 6 months, right? A physician has to keep certifying that the prognosis is a limited life expectancy in order to stay on Medicare benefits beyond 6 months. And so we hear of cases of hospices in this country that discharge patients alive, right? Because the funding goes down with the amount of time someone's on hospice, and because it requires a lot of recertification process. And sometimes it's appropriate. We will discharge someone off of our hospice care alive because their curative treatment has gotten them better, and they're really not going to die anytime soon, right? So it's not unacceptable to discharge someone live from hospice, but it shouldn't be happening a lot. And so it does happen a lot at certain hospices in the US, and that has been getting some attention on the national news level. And that's gotten some attention at the federal level, that there needs to be some change to the hospice benefit. As I said, there are different areas where the care can be received, and depending on what the patient need is, there's the home-based care. There can be continuous home care with someone coming in on a regular basis to care for a patient who doesn't have sufficient caregiving. There's inpatient care. There's that's acute and ongoing. At volunteer hospice, we can only provide care in the home setting, only in the setting where a patient has sufficient caregiving, where someone can have 24/7 eyes on the patient. Not that they are getting 24/7 eyes on, but there is someone around to care for them on a regular basis. So we are unique in that we cannot provide these other levels of care at volunteer hospice. The other hospice in Clallam County, Assured Hospice, can potentially, because they should be able to bill for those services. And I think they do that as a partnership. I'm not exactly clear on how they do that. As I said, hospice referrals, it's not Grim Reaper. It can actually be beneficial to a person. It provides a team that manages pain, other symptoms of discomfort. It provides medication support, medication supplies with Medicare hospice. We do not provide supplies. It also provides durable medical equipment. DME stands for durable medical equipment. It provides coaching to families and patients. So the care at home is the best possible. It reduces symptom burden, reduces depression for both the patient and family, caregivers, anyone associated with that end of life period. Provides needed end of life education. And it allows patients to stay at home through the end of life. As we know, greater than 80% of Americans want to die at home. It grants that wish for many. It increases patient and caregiver satisfaction with care. It supports the emotional, psychosocial, and spiritual aspects of caring for someone with serious illness and/or is dying. And after the patient has died, it provides bereavement, ongoing bereavement care and counseling, and it's controversial, there's anecdotal data, but may actually increase survival rate for the patient. Bottom line, it improves the quality of life before and after the patient's death for the patient, family, caregivers, and everyone associated with the process. So when it comes time to choose a hospice, generally everyone's lost. And in larger cities like Seattle, and where there are multiple options, people are like, how do I choose? Well, there's organizations like the Washington State Hospice and Palliative Care Organization that actually provides some questions that an individual can ask. So if you have a loved one living in LA who is going on hospice care, go to the WSHPCO website and look up how to ask the right questions to choose a hospice. This is something that is extremely valuable. Use those resources. There's a ton of resources out there, and it will tell you, what questions to ask, and it will help you be more informed if you're supporting someone that's considering going on hospice care. As I said, hospice is evolving, partly because it's over 40 years old, and partly because of these statistics that have been publicized on MSNBC and NPR and the New York Times. All of these stories are coming out highlighting some of the hospice fraud and profiteering issues that are out there. Just remember, it is a profitable business. $2.3 billion, I think, is the number that I said of how much Medicare hospice paid out, right, in 2021. 75% of hospices in the nation are for-profit businesses. And those are the businesses that are getting some of this profiteering and fraud issue being brought up. The majority of the issues that are highlighted are in this 75% category of for-profit hospices. Now, I'm not saying 75% of the for-profit hospices that exist are all doing fraud. No, a small, tiny percentage of them are. And they are the bad actors that are causing a bad name for hospice in the nation. And because there's that small portion, the government is paying attention. Organizations like CMS are looking at visiting all hospices nationwide, increasing oversight, and piloting programs to review eligibility criteria. Organizations like the National Hospice and Palliative Care Organizations, and organizations that don't usually come together, are coming together to make recommendations to the federal government, to CMS, to Congress, saying these are the steps you need to take and in order to improve hospice care and decrease profiteering, decrease fraud in the hospice industry going forward. And there is going to be an evolution as we move forward. So all that to say, let's come back to Clallam County. So if we go to Clallam County, let me just give you not demographics that you're not aware of, just want to position it so that we're all in the same place. Clallam County is an ages older than the majority of counties in the US, right? We have a state rank of 5th oldest population in the state of Washington. Just as an aside, Jefferson County is the oldest ranking population in the county in the state, right? We are the 5th oldest in Clallam. Population that's greater than 65 is almost 30%. The median age in our county is 50.8, almost 51 years old, right? our county ages older. So it is important that we think about hospice and palliative care. And as we think about it, there are two options in this county. As I mentioned, there is Assured Hospice, which is a Medicare licensed hospice. So patients being cared for Assured in both Clallam and Jefferson. Their area of coverage is Clallam and Jefferson. Assured bills hospice for that care. They are now a part of United Health Group. They were acquired in February of this year. They used to be part of Louisiana Hospice Care Group, LHC Group, which was an organization founded in 1994, headquartered in Lafayette, Louisiana. It had 960 locations across 37 states with a revenue stream of $2.2 billion in 2021. They were acquired by United Health Group in February at a price tag of $5.4 billion. They are a for-profit hospice. They are a good hospice. They are not the fraud profiteering hospices. Let me be clear on this, right? They are not the bad guys. They are not that small percentage of bad guys. They are a Medicare billing hospice that does care just like any Medicare hospice, right? They're part of the healthcare services of United Health Group known as Optum. Are they needed in our county? Absolutely, they are needed in our county. They serve a valuable portion of our county. Our county also has a second option, and I tend to be a favor of that because I work at Volunteer Hospice of Clallam County. And I have to say, it is an incredible organization. It is like 1 in 5, maybe 6 in this nation that does all of the service gratis to every single person on the caseload, no charge to the patient whatsoever. We're not billing Medicare, so the patient's Medicare isn't being billed. We're not billing an insurance company. We're not billing the patient or the family. We do everything for free. And we do it because of the generosity of this community that continues to give to support a $1.7 million annual budget. We have paid professional nurses, CNAs, and mission support staff that are funded because this community supports it, not because we bill Medicare and Medicaid. 1 in 6 in the nation, 1 in 5 in the nation, something like that. And we're able to operate because Rose Crum, when Medicare was coming into the picture, said, I don't want to be billing Medicare. I want an exception. She, her son Patrick, and Derek Kilmer, who was in the state legislature, carved out an RCW exception for us to exist. We are very weird in a good way. Our service goes between Joyce and Diamond Point. We do not, unfortunately, serve all of Clallam County. We are hopefully going to be supporting people so that the West End can be supported more. It is a challenge with a geography that is so large. Our care team is not as interdisciplinary as that large team that I talked about with general palliative and hospice care. Our care team involves nurses and CNAs, who are the predominant people that go in for eyes on a patient. So we have the core team that is needed for the best care for our patients. And the care is person-centered care. Person-centered, centered around the patient need, the family need, the physician need, the caregiver need. It is person-centered. We do not have restrictions. So if a person really does have a certification of terminal illness, but wants to pursue curative treatment, they certainly may. There is no issue to that. Again, let me say, generally at end of life, do you really want to be pursuing aggressive treatment? Probably not. So that exception, yeah, while it's great, it is not saying that that's, it's not incredible, but it is important to know that if there's an opportunity and the patient wishes to do it, it is patient-centered. So if a patient wants to pursue curative treatment and still has less than or 6 months to live, they certainly may. Right? If they want to go to the emergency room, they certainly may. They may pursue aggressive therapies and treatments, and it has no impact on whether we provide that service. So we're kind of weird. And oftentimes people are like, well, you're so weird. Are you real? And it's like, no, we're free, but we're real. Okay. We're 100% free for everybody. We're community funded through donations, fundraising, plan giving, and grants. We have over 180 volunteers, and Astrid, I think Raffin-Pelos is on this call, on the Zoom, and she is the one that is our volunteer services manager, extraordinary individual who coordinates 180 people who do volunteer stuff all the way from respite care to grief support to lending closet to all of these programs that we have, which I'll touch on in just a minute. We have 11 volunteer board members. We have a paid staff, 13 registered nurses, 3 certified nursing assistants, and 5 mission support. I'm on the mission support team, and yes, I am paid. And our evolution, just in that little history dot piece, Rose Crum, the visionary that created us 4 years after the concept of hospice came to the US. In 1978, Hospice of Clallam County was born, has gone through evolution. When Medicare funding came in, Rose went with her son, Patrick Crum, and Derek to the legislature, got our RCW exception. So we have a licensure exemption. So we do not have to bill Medicare for our services. We became Volunteer Hospice of Clallam County in 2006, and we continue to support our patients. While we do not say one way or another with regards to death with dignity, medical aid and assistance in dying, we will support with hospice and palliative care. We do both hospice and palliative care, so more than 6 months to live. We will support a patient's decision. They have the right to choose. If someone wants to pursue something like death with dignity, we guide them to End of Life Washington so that they can get supported in that. We support the hospice and palliative aspects of their care. We have a $1.7 million budget, and we've been in existence 45 years as of this May, which is an incredible thing. And the history of VHOCC is a beautiful story, made more beautiful by the extraordinary vision and foresight of its founder, Rose Crum. In carrying out Rose's vision, VHOCC has become a beloved and vital part of the local community. We do both hospice and palliative care. Very unlike most hospices in this nation, we support patients to ensure they are physically and psychologically as comfortable as possible through the life-limiting end-of-life process. Focus is on mitigating consequences of the disease, not the disease itself. We're not helping with curative treatment. We're not helping with the cancer care. We're not helping with the heart disease. We're helping with improving quality of life for the patient, family, and caregivers, providing relief for symptoms and pain, decreasing psychosocial distress, and addressing emotional and spiritual needs. We strive to match comfort care options with patient and family goals, person-centered. We work as a team in conjunction with the other providers. We come alongside, we do not take over, right? We come alongside. You keep your own physician, you keep your own social worker, you keep your own therapists, you keep your own pharmacy. All of those ancillary supports continue. We come alongside with that group. And we serve the community that helps us exist. Organizational capacity, as of last month, our census was 116. For the month of November, we served 116 people. 39 of those individuals were hospice patients, 77 were palliative. The majority of our caseload is palliative. It is important. A non-funded aspect generally is what we mostly care for in our caseload. And our census has gone as high as 160. We are striving to increase this on a monthly level, but we can do only as much as we can. The most important thing is the best care for the people that are on our service. Referral averages between 10 and 30 monthly, and the level of need determines the admission appointment. So contact frequency is variable based on the level of need, and I will just leave this here. I don't want to belabor this. Bottom line is patient-centered. What the patient and family needs is what we try to deliver. That is the bottom line from this slide. There are times where we can't admit patients. As I said, we are that hospice that doesn't have a facility, so we can not offer support for someone who doesn't have sufficient caregiving. That is an important piece. And that is a crisis that Petra talked about last time on this series. And it is something that needs to be resolved. Again, a point of, if you raise your voice somewhere, raise your voice about getting the caregiver crisis solved, right? I mean, there is an economist out of New Zealand who says, GDP, gross domestic product, is a system that counts oil spills and wars as contributors to economic growth, while child rearing and housekeeping are deemed valueless. That's insane. It's considered valueless to be a caregiver for someone. That is crazy, right? That needs to be fixed. But that is a mechanism by which you might not get service because you don't have sufficient caregiving. A patient can refuse service, or if our capacity is overburdened, that might be a reason as well. But we are not just about hospice and palliative care. We also have a grief and bereavement program, which is also managed by Astrid Raffenpelos, who is an amazing person. We have individual grief support groups, practical workshops, an annual remembrance ceremony, which is happening February 10th, 2024. Mark your calendars. We have soul care, death cafes, Tea to Die For. We have a speaker series. We have death companions. We have death doulas. We have a lending closet that's open to anyone. People can take advantage of our grief and bereavement, our soul care program, our lending closet, even if they're not on our caseload. Our lending closet lends to anybody who walks into our Port Angeles office if we have the capacity to do that and have what they need.
I have benefited from that lending closet.
Thank you,
It's
Vicki.
terrific.
I'm glad to hear that. There's no time limit for the loans, and donations are also accepted. We accept from the community, we give back to the community. We have our grief and bereavement program. I'm not going to belabor this, but there's a lot going on. And what I will do is I will send these slides to Karina so that she can share this with you. So you have this. I have these things highlighted because there are separate flyers that have been developed for this. I will send those flyers as well, so you can get more general information about our grief and bereavement programs, our soul care programs, and what's scheduled currently. Our lending closet, as I said, we have medical equipment available to anyone in the community at no charge, so long as we have it. And our hospice and palliative care patients are served first. They come first. But if we have it and our hospice and palliative caseload is covered, then we will make it available to the community. We have equipment and supply delivery to patients, and beds are delivered even to non-patients, and some other equipment. Supplies, a limited number like incontinence supplies, are also available for the community. There's no time limit on loans. They're all free, and we do accept donations. Our service numbers January to June, so a 6-month period, we had 190 patients on service, 1,100 nurse visits, almost 600 CNA visits, 2,000 direct patient support hours, 109 admissions, 83 deaths, 974 hours of spiritual respite, grief, bereavement support, 2,078 visitors to the lending closet. It's a lot. That's the bottom line. It's a lot, right? And this number hasn't been updated, but over 180 volunteers. And we do this with a $1.7 million expense budget, but we do have a gap, so we do continue to accept money so that the gap between the income level and the budget continues. And a lot of volunteers, 180 volunteers and 5,000 hours, right? So I just want to end with a few final tidbits. Epictetus, I think that's how you say it. Old philosopher, I cannot escape death, but at least I can escape the fear of it. That's what hospice and palliative care is, right? It's about taking the end of days and adding life to those days when those days cannot be added to life, right? Death is a tornado of thoughts, fears, visions, and emotions. Hopefully we, with hospice and palliative care, can decrease the fear and improve the emotions. So if nothing else, plan and talk about end of life. For you, for your loved ones, for your friends, talk about it. How would you like to die? Who's going to be the advocate? Who's going to respect your wishes, right? Who is actually not going to overstep, right? Who do you have as the right providers, the family, the caregivers, the right agencies, the right care facilities? Who is that? Do you have the right documents in place? Talk about it. The person, and then the other piece, then I read an article that was shared by our clinical team manager, Haley Blackburn Jacobs, recently, which talks about oftentimes you go to visit someone who's dying and you don't talk to them like a person. The person who is dying is still a person. Visit the person, not their disease, not the medicalization, not the diagnosis, not the prognosis. Visit the person. Don't treat them like a dying person. Treat them as a human being. That is what they are. Show up, pay attention, tell the truth, and don't be attached to the outcome. Yes, they may be dying in an hour. They may be dying next week. That's not the point. You are there to visit them as a human being that you've cared about and loved all the time that you have been in conjunction with them. Be that person with them still, right? A few resources, and then a thank you and some general information about how to contact me. All of this will be available on slides afterwards. And I will stop share there and ask for questions.
And you're
and
funny.
Colette is on, who is one of our volunteers. Thank you, Colette, for being an awesome volunteer.
Okay.
I do have a question.
Yes.
Should I start?
Yes.
That-
So if a person says to me, I have a family member that I believe is ready for hospice. What are the steps? How do they initiate becoming a patient?
There must be a referral from a provider. A physician, their primary care provider, must make an assessment that they are experiencing a life-limiting illness and are ready for either hospice or palliative care. So that referral is the front door to our services, to Assured Services, to anybody's hospice service.
So how do you get that referral? Does the doctor know it or do you ask for it?
You can, a family patient can certainly ask for it. It is a conversation between the patient and the doctor can make that decision, or the patient can ask that the doctor make that decision.
Okay.
Yes,
So I would advise them to ask their doctor for a referral.
absolutely. Absolutely. Yes.
And then do you call them or after the
So-
referral's made? And the
When a
patient-
referral is made, there's paperwork that comes in the door, and we ask for a specific set of things. We have to have a standing order, emergency orders. We have a certain amount of paperwork that must come from the provider to us. And that, if the provider, the PCP doesn't give that to us to begin with, then we call them back and say, we need this, da, 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 da. And then afterwards, we may get all the paperwork in, and then we may have some gaps in what we need as information before we schedule an appointment with the patient. So we call the family, the patient, and schedule that initial admission visit, and we may ask for additional information at that point as well. Yes.
Thank you.
Absolutely. Melissa, did you have a question?
I think part of it's been answered by what she said, because I've kind of heard some stories about it being hard to get onto hospice. And I also have one other side question, which is I happen to live in Gardner. So I'm thinking none of your services are available to me at this point in time. I'm Jefferson, even though my post office is Squim. It's crazy.
So I don't know if we've had people in Gardner. We've definitely had the tail end of Diamond Point. We've had patients in. We don't currently serve anyone in Gardner. Assured does serve in both Jefferson and Clallam, so Assured is available. And then to our services, that is, you can actually use our lending closet still. You can still use our grief and bereavement. You can use all of those things. And then going back to your first comment about it can be hard. Remember that hospice and palliative care, remember our caseload, right? We're generally, in 6 months, we've served about 190 patients, right? We serve the patients that need us most, right? If we bring on someone who really isn't at that end of life, last few months, period, then we are doing a disservice for the people that really need us when they need us. Right. So we are selective in that we're not bringing someone on to stay on our service for 10 years. Although we did have someone on our service for 10 years. But that's because they actually do have a life-limiting illness, and some of our parameters were a little bit more flexible in the past. And we do have people who have stayed on our service because we have palliative care for 2-3 years. If you really have a life-limiting illness where you need an RN and a CNA to come in and support comfort and pain management, then it is worth seeking that referral and for us to come in and make an assessment. Because the other piece is that once a referral is made, it is alive for 6 months. We may come in and do an admission visit and say, you may not be appropriate for care, but you're in a status where if something changed overnight, we could get you back onto caseload faster than if you didn't have that referral and that pre-admission, right? Already in place. So
Okay.
yeah, I don't know if I've answered, but yeah.
No, thank you. That helps.
Yep, absolutely. Did I stay in my time frame?
No, absolutely. You've done great. We technically have till 12:30. So
Oh, okay. Phew.
anyone else has a question, feel free to chime
So,
in.
so I see Linda Mellis has the question, what are the requirements for getting on palliative care? So it's, again, an assessment tool-based approach when we bring someone on care. So we have some specific assessment tools that we use. So we have some ranking criteria. We have some scaling tools, like there's a FAST tool. There is a palliative and PPS scale. I forget what that stands for, but there are these scales that we use. So when someone comes on and to an admission visit, the nurse comes in, and oftentimes the admission visit is like 2 hours, sometimes 4 hours, because we are getting a full picture of the human being that we are talking to, right? And their family dynamics, their care, their medical condition, their everything. And in that assessment, we have toolkits that we go through. Okay, they need this much support with their activities of daily living. They have had this many emergency room visits over the past 6 months. They walk with a walker. They're not mobile. They are more bedbound. There's all of these parameters that we go through checklists in order to give scoring to. And based on that scoring, actually, I may be able to pull up our process for admission. Give me 1 second. I can show you. This is probably a little too technical, but at least you can see it. We have this process whereby we say, when we get a referral, we call the patient and family, we confirm, all these parameters, we schedule the patient visit, and we go through these criteria. Do they meet hospice criteria checklist? And we have a checklist for that. If they exhibit one of the criteria in that checklist, and I don't have the checklist here, and they have a primary diagnosis category that meets the criteria, then yes, they go into hospice. Does the patient want service? Are they ready to start service? Do they have sufficient caregiving? Yes, they get admitted. If they don't meet all of these parameters, then there's a team evaluation. Do they go into hold status, or are they a consult only? And once they get certain things in order, then we can switch them to hospice service. But if they don't meet the hospice criteria, then there's some questions we ask about. Do they meet the criteria of being seriously ill based on this scaling tool? Right? If yes, then do they meet this level of criteria? If yes, then they may be admitted if they meet these parameters. So we have this kind of flow process for evaluating and determining if someone is appropriate. Does that answer your question, Linda? Hopefully.
I just wanted to say I need to leave, and I want to thank you immensely for the
Absolutely.
presentation. It's a fabulous piece. Look forward to
Absolutely.
seeing the materials. So great to know about the work you do.
Thank you. And if you ever have any questions, do not hesitate to contact me. I love talking about this stuff.
Yeah.
And I love to make that end of life process as emotionless and pain-free and comfortable as possible.
I'm going to explore your Death Cafe here. I was a facilitator for about 6 years in Portland for Death Cafe we had there under.
We can use another
Ollie
facilitator.
through it. We'll see. Thank you so much, everyone. Bye-bye.
Bye. Yeah, that's another piece. So if you would like to join Colette in our volunteer cohort, we would love to have you as part of our volunteer pool as well.
Priya, Linda put in the chat, she's curious if you could also share that page.
I
you
will
just
add
shared.
that to the slide presentation and when I send it. Absolutely.
Any other questions? All right. I'm going to go ahead and resume. Oops, sharing my screen and say thank you, Priya, for this incredibly helpful presentation. I think I finally understand the difference between palliative and hospice. So when people ask me, I've had many people ask me since the program was publicized, I'm like, we're going to find out together. So thank you so much for the clarification and all that you do. It's just makes me so happy that that is happening for folks who need it. So thank you so much, Priya. And let's see what is coming next. Oh, as usual, if you want to find out more information about volunteer hospice of Clallam County or palliative care or hospice care, I have collected some resources as well. And I encourage you all to explore them if you're wanting more information. Some of these are online resources and some are resources available in the library collection. And all of this will be included in that email that I will send you all next week, which will also contain the link to this recording. And then that brings us to next year. Our first installment of Aging Well is going to happen on February 20th here on Zoom at 11 a.m. And we will be joined by Grace Lambert, who is going to talk about posture exercise therapy. Grace is a posture therapist who practices in Sequim, and her passion for posture therapy grew from the relief it gave her after years of chronic pain. So join us on Zoom in February to learn more about the gentle corrective movements of posture exercise therapy. And that is all for today's program. Thank you again to Priya for joining us. And thanks to all of you for taking an interest in living well as you age. Take care, everyone. Enjoy your holidays. Enjoy the new year. And I will see you all in February. Take care.